today we are having a pleasure to have this meeting as a joint meeting with Retina Hub Academy with my friends, Dr. George Roca. So today we are having two parts of the meeting. The first part, it will be by Amiom, it will be a Bushel Lump Symposium, and it will be delivered by Dr. Ivana. Dr. Ivana is a staff physician at Cleveland Eye Clinic, Abu Dhabi, Eye Institute, Abu Dhabi, UAE, and she is a refractive and cataract refractive surgeon. Am I right, Dr. Ivana?
Yes, thank you.
So the floor is for you, and thank you.
Thank you, Dr. Mohammed. I will share my screen. You can see my screen, right?
Yes, we can see you. We can see you. Yeah, go ahead, please.
Thank you. Good evening, everyone. Thank you for inviting me to this meeting. It's my pleasure to talk about the advances in the diagnosis and treatment of dry eye disease. So why do we talk so much about dry eye disease? We all know it's a highly prevalent condition that affects millions of patients around the world, and it's one of the most common reasons for patients to seek eye care. It can have a significant impact on patients' vision, work productivity, daily activities, and of course, quality of life. Also, it can adversely affect the outcomes of ocular surgery. So untreated dry eye disease can lead to inaccurate pre-surgical measurements. We can have IOL calculation errors, refractive surprises, reduced quality of vision, visual fluctuation, and worsening of dry eye symptoms postoperatively. Pathophysiology of disease is complex, and in the last 2 decades, many new concepts and definitions have been proposed in order to assist in explaining this complex pathophysiology. But what we know is that the core mechanism is tear film hyperosmolarity, which is a result of tear film instability, either as a result of reduced tear production or excessive evaporation. And tear hyperosmolarity damages ocular surface both directly and by inducing inflammation. When diagnosing disease, there are several challenges that we are facing. There is a poor correlation between subjective symptoms and objective signs. Our traditional diagnostic techniques are largely subjective, variable, and often unreliable. We don't have a single diagnostic test that can diagnose dry eye disease, and also other conditions can mimic dry eye, such as ocular allergies. And this is because dry eye disease is not a one disease. It's a disease that can have different symptoms. We have some patients complaining about burning, pain, discomfort. Others are complaining about visual disturbances. And also there are many different clinical signs. So dry eye disease is more like an umbrella term that incorporates different diseases with different underlying pathophysiologies. And these different diseases, they have a different response to different treatment options. So our role is to make a correct diagnosis and to choose optimal treatment for our patient. With the recent advances in technology, we are now allowed to better recognize and manage patients with dry eye disease. And in order to incorporate modern diagnostic and treatment approaches, free clinical evidence-based algorithms have been proposed in the last 10 years. The one that is the most known is definitely the Tear Film and Ocular Surface Society Dry Eye Workshop 2 diagnostic algorithm. This algorithm starts with the triaging questions to exclude conditions that can mimic signs and symptoms of dry eyes, and with a risk factor analysis to establish a suspicion of dry eye disease. And the diagnosis is established based on symptoms, either OSDI score more than 13 or dry eye questionnaire score more than 6, plus at least one sign of reduced homeostasis. And this can be reduced tear breakup time, increased tear osmolarity, or ocular surface staining. If dry eye disease is ruled in, then the second step is to identify a primary subtype. Is it evaporative, aqueous deficient, or a mixed spectrum? And to do so, we have to do some additional tests like meibomian gland imaging, measuring lipid layer thickness, or tear meniscus height. This is another algorithm which was proposed in 2017 by the Cornea External Disease and Refractive Society, which also gives recommendation for dry eye management. And it offers a diagnostic-based approach where patients are categorized based on the predominant etiologic mechanism of dry eye disease into 4 categories. So we have tear deficiency, we have goblet cell or mucin deficiency, blepharitis, MGD, and exposure keratopathy. And the treatment is recommended based on the category or type of disease. In 2019, the ACRS preoperative ocular surface disease algorithm was created by the Cornea Clinical Committee of the ACRS. And the purpose of this algorithm was to simplify screening for ocular surface disease before refractive and cataract surgery. This algorithm recommends screening for ocular surface disease. Oh. Sorry. I can continue.
Yeah, please go ahead. There is no interruptions. Sorry.
No worries. So screening for ocular surface disease starts with symptom questionnaire, SPEED 2, and testing tear osmolarity and MMP9. And then a clinical exam is performed to confirm a diagnosis of the ocular surface disease. And if ocular surface disease is ruled in, then we have to determine is it visually significant or non-visually significant. And based on that, we will decide when to proceed with the surgery. So the goal is to restore ocular surface homeostasis and proceed with the surgery once ocular surface disease is considered to be non-visually significant. We have many diagnostic tools available for diagnosing dry eye disease nowadays. Symptom questionnaires are excellent first step. They can identify patients who are affected by dry eye. They accurately quantify symptoms, and they can guide us whether to proceed with additional evaluation. They can be also used to monitor progress of disease and response to treatment. And usually they measure ocular surface discomfort, vision symptoms which are associated with dry eyes, and the impact of dry eyes on everyday function. There are many symptom questionnaires available, but the TIFOS US2 committee recommends use of Ocular Surface Disease Index and Dry Eye Questionnaire 5. OSDI questionnaire contains 12 questions. It's measuring frequency of ocular symptoms, environmental triggers, and vision-related quality of life. And the score above 13 means that there is a mild disease. Above 23, it's a moderate, and above 33 means that there is a severe dry eye disease. Dry eye questionnaire 5, it's much shorter. It has only 5 questions. It is asking patients about eye discomfort, dryness, watery eyes, and about intensity of symptoms. And the score above 6 means that the patient has dry eye disease. When doing clinical evaluation, of course, we start with a comprehensive external and a slit lamp exam. We have traditional tests, tear breakup time, ocular surface staining, Schirmer test, diagnostic meibomian gland expression. And we also have a newer point of care diagnostic test. Traditionally, tear film stability and volume are assessed by fluorescein tear breakup time and Schirmer testing. And these tests are still essential component of the ocular surface exam, but they have some disadvantages. And this is mainly poor repeatability, and they're pretty much subjective. The other option is that we do a non-invasive tear breakup time, which can be done with a topography-based imaging system. It gives us automated measurement of tear breakup time based on the distortions of the Myers, which are reflected from the precorneal tear layer. And the studies have shown that it has a better sensitivity and specificity compared to invasive tear breakup time, but still it did not become a part of the routine dry eye exam. We can also measure lipid layer thickness with interferometry. And this measurement, we get a quantitative measurement of the lipid layer thickness. And if it's less than 60 nanometers, it has a 90% specificity for meibomian gland dysfunction. And it correlates well with the symptoms and signs of dry eyes. but it does not reflect quality of the lipid layer. And we need more study to determine the precise role of this measurement. Tear meniscus height can be measured, of course, on the slit lamp, but we can also do non-invasive measurement with the anterior segment OCT. But despite being a non-invasive, it still did not become part of the routine dry eye exam. Ocular surface staining is, of course, the important step in the exam. We do fluorescein corneal staining and lissamine green conjunctival staining. And a positive score is above 5 corneal spots and more than 9 conjunctival spots. And we use Oxford scale for grading of this surface staining. Nowadays, we also have a point of care testing, which has revolutionized the diagnosis of dry eye disease. It gives us objective data, which are gathered from the tear film. It allows for earlier diagnosis, and also it can be used to monitor therapeutic responses and to identify masquerading diseases. This is a list of point of care testing I will be talking about. First one is tear osmolarity testing. To do it, we need only a 50 nanoliter sample of the tear fluid from the lateral tear meniscus. The most well-known device is a tear lab device, which uses electrical impedance to measure tear osmolarity. And the abnormal value is above 308 milliosmoles per liter in either eye, or the difference more than 8 milliosmoles per liter between the eyes. And tear osmolarity is showing a stronger correlation with the severity of dry eye disease compared to ocular surface staining or tear breakup time. The only limitation is that tear osmolarity cannot distinguish between types of dry eye disease. And then we have MMP9 testing. MMP9 is inflammatory mediator. It's released by distressed epithelial cells, and it's found elevated in patients with dry eyes. Nowadays, we have inflammatory test. It's a point of care test that measures the level of MMP9. And the positive test means that we have abnormally high MMP9 levels. So that means about 40 nanograms per milliliter. And it's very helpful because it can tell us when to start treatment with anti-inflammatory medications. We can do tear protein testing as well. There is a tear scan device which measures the amount of lactoferrin and IgE in the tear film. These biomarkers are important in differential diagnosis of dry eye disease and the ocular allergies. So if we get a low lactoferrin level, this indicates that patient has aqueous deficient dry eye disease, and the high IgE, of course, it's a sign of ocular allergy. But it doesn't only confirm diagnosis, it can tell us how severe the disease is. Dynamic meibomian gland imaging is a great testing modality. It has revolutionized the way we can explain meibomian gland dysfunction. It's using transillumination technology, and it can help us to see meibomian gland structure. We can look at the duct dilation, constipation, shortening, and the dropout of the glands. And it's useful in stratifying disease severity, and it's also excellent patient education tool. By showing the patient, we can motivate patient at least to perform preventive care. Shaw serum test is another test that is worth mentioning. It's relatively new. This is an in-office diagnostic blood test. It can help us to identify Sjögren's syndrome based on the presence of the certain biomarkers. So it has it contains 4 traditional antibodies, but also some new biomarkers. And it's important because we can make diagnosis of Sjögren's syndrome earlier, and this is important because it can be associated with systemic diseases. So let's talk about the treatment. So when deciding about the treatment, we have to remember that the main objectives are improvement of ocular comfort and quality of life, and returning the ocular surface and tear film to normal homeostasis. Treatment options, of course, during time, they have dramatically increased, but the TIFOS DUCE2 committee, they recommend a stepwise approach in the treatment based on the disease severity. And they proposed a 4-step algorithm. Step 1 includes patient education, environmental modification, dietary recommendation, use of artificial tears, eyelid treatment, warm compresses, and eyelid hygiene. Then in step 2, we have treatment with anti-inflammatory medication, topical and oral antibiotics, use of punctal plugs, and in-office meibomian gland procedures. Step 3 includes treatment with oral secretagogues, autologous serum drops, and therapeutic contact lenses. And step 4, it's reserved for refractory dry eye disease for cases which may require long-term topical steroids, amniotic membrane grafting, or surgical interventions like surgical punctal occlusion or tarsorrhaphy. Artificial tears, of course, they are a mainstay of treatment for all severity grades of dry eye disease. And when selecting the right drops for our patients, there are several variables that should be considered. We should look at the concentration and choice of electrolytes. We should look at the polymers they contain, and of course, if there is a presence of preservative, and if yes, which one is present. We know that inflammation has a very important role in a dry eye disease. A long time ago, in 2007, Baudouin proposed the concept of vicious cycle of inflammation, which is a core driver of dry eye disease. And breaking the cycle was reported to be an important step in the treatment of our patient. So how can we break this inflammatory cycle? Well, we have several anti-inflammatory therapies available. We can use smart steroids. We have T-cell inhibitors and anti-integrin small molecules. Steroids are great and very effective, especially in the treatment of acute flare-ups, which require rapid relief. And loteprednol etaponate 0.5% is the first smart steroid that has a good anti-inflammatory capacity with a safety profile from IOP stand of view. And now we have a new nanoparticle formulation of loteprednol etaponate 0.25%, which is using a mucus-penetrating particle drug delivery system. This improves penetration into ocular tissue. And this is the first FDA-approved steroid for short-term treatment of dry eye disease and has done very well in the phase 3 clinical trial. Another group of anti-inflammatory medication used in the treatment of dry eye disease are T-cell inhibitors. We have cyclosporin 0.05%. This is the first FDA-approved anti-inflammatory medication for dry eye disease. It was approved in 2003. This is an immunomodulatory drug with anti-inflammatory properties. It inhibits activation of T-cell lymphocytes. It's decreasing inflammatory cytokines, and it's also increasing a goblet cell density. And we also have cyclosporin with a higher concentration, 0.09%, which was FDA approved in 2019. And it also utilizes nanomicellar technology, which gives a better penetration through the aqueous layer. And the phase 3 clinical trials showed improvements in signs and symptoms of dry eyes, which are seen earlier than with the lower dose cyclosporin. And now we have a new T-cell targeted therapy, anti-integrin therapy, lifitegrast, which is the only non-steroidal anti-inflammatory medication FDA approved for the treatment of both signs and symptoms of dry eye disease. It interacts with the integrin LFA1, and it inhibits T-cell recruitment, activation, and release of the cytokines. So it works as a LFA1 antagonist. LFA1 is a lymphocyte function-associated antigen 1. So lifitegrast blocks binding of LFA1 on the ICOM molecule, which is the intercellular adhesion molecule 1. And this is how it inhibits T-cell recruitment. It was FDA approved in 2016, and as I mentioned earlier, for the treatment of both signs and symptoms of dry eye disease. And 4 randomized multi-center 12-week clinical trials were done to evaluate the efficacy and safety of lifitegrast compared to the vehicle. And they were looking at the improvement in clinical signs, which were measured by inferior corneal staining score, and improvement of symptoms measured by eye dryness score. And they found that in patients treated with lifitegrast, symptoms reduced after 2 weeks in 2 out of 4 studies, and after 6 weeks in all 4 studies. And the improvement in inferior fluorescein corneal staining was seen after 12 weeks in 3 out of 4 studies. It's also important to mention treatment for MGD because more than 85% of patients with dry eyes have MGD component. So of course we have warm compresses and eyelid hygiene as initial treatment, but we also have a topical lipid-based lubricants. We can use topical azithromycin, oral doxycycline, minocycline. We have omega-3 supplements. And we have this in-office procedures like microblepharoexfoliation, thermal pulsation therapy, IPL. And there is a new LIDS. It's a new device. It's a portable handheld system which can be used at home. It cleans, massages eyelids. It removes bacteria, biofilm, and the dead skin. And studies have shown that it leads to statistically significant improvement in OSDI score, tear breakup time, and ocular staining score. We have some new treatment options which are recently FDA approved. We have varenicline, which is a selective nicotinic acetylcholine receptor agonist. It works by activating trigeminal parasympathetic pathway in the nose, and this is then increasing basal tear film production. And this is the first FDA-approved nasal spray to treat signs and symptoms of dry eyes. Then we have perfluorohexyloctane, which was FDA approved in May 2023. It's mainly recommended for treatment of dry eyes associated with meibomian gland dysfunction. And this is actually the only medication that targets excessive evaporation, which is the underlying cause of meibomian gland dysfunction. Another medication worth mentioning is lotilaner ophthalmic solution, which is FDA approved last year as well, and it's used for the treatment of Demodex blepharitis. And we have now cyclosporin 0.1, FDA approved in June 2023, and it was also approved for the treatment of signs and symptoms of dry eyes. This is a device worth mentioning. It's called Lacrifil canalicular gel, or a cross-linked hyaluronic acid-based canalicular occlusive device. It was recently FDA approved, and it has a benefit. It's offering a superior punctal occlusion compared to typical punctal plugs that we are using. There are some emerging therapies for dry eyes as well. We have selenium sulfide, which targets abnormal hyperkeratinization. It's used as the ointment, and it's applied twice weekly at bedtime. Then we have ripraxolab, which is a new investigational therapy. It targets reactive aldehyde species, which are at the top of the inflammatory cycle. So this is another anti-inflammatory medication. We have a melanocortin agonist, which work by activating endogenous melanocortin receptors. We also have OCS2. It's a topical anti-TNF alpha agent, so it works by inhibiting inflammatory cytokine TNF alpha. And there is another medication, AR15512, which mainly activates transient receptor potential melastatin 8, and it's increasing basal tear production. So in conclusion, enhanced understanding of the immunopathogenic mechanism of dry eye disease has give us a meaningful framework to facilitate an evidence-based approach for dry eye disease diagnosis and treatment. New diagnostics help us to identify dry eye subtypes and help us with the proper treatment. We know that inflammation plays a critical role, and MMP9 is a marker of ocular surface inflammation. We use topical steroids, and they're mainly important for treating flare-ups, but have to be used with carefully with a caution. We have T-cell inhibitors, which can inhibit both subacute and chronic conditions. And development of the new anti-inflammatory therapies, such as topical biologics, will be part of the future of dry eye treatment. Thank you.
Thank you very much, Dr. Ivana, for this excellent and comprehensive talk about dry eye disease, which is a well-known disease that affects a lot of population worldwide, and especially in our area. I think you are now in UAE, and you can see that. I think if we say 99% of all our people, they are suffering of dry eye, maybe, but in a different percentage of severity. Because we took a lot of time, but it was a great talk. I will ask only one question if there is any comment from other colleagues before asking them questions. Any of our colleagues here want to comment or to ask any question to Dr. Ivana? Yes, Dr. Nicholas, please go ahead.
Okay, thank you, Dr. Ivana, for this detailed and thorough presentation. My question is regarding real life evidence. In case a patient walks to your office and asking for the trifocal lenses, and probably you're doing the trifocals as well as a refractive surgeon. So what are the tests you do to find out whether this patient is having dry eye disease, or what's the severity if he or she is having the dry eye, and what's the consequence of the tests you are doing, and what's the cutoff line when you just recommend the patient against the trifocal lenses and recommending the monofocals?
I would say, thank you for your question. So definitely ocular surface staining is a sign that we should not proceed with the surgery. So we have to start treatment first, to follow up with the patient and see the progress. And another very important test for this patient, I would say, is inflammatory test, which measures MMP9 level and telling us if patient has inflammation. And based on that, this test, we can decide whether to start anti-inflammatory treatment before surgery to properly prepare, especially for these patients who will do trifocal or any kind of modern lenses, which require perfect quality of vision.
Okay, so except the tear breakup time and the Schirmer test, which is a more conventional and traditional, you do this two tests with the staining and
inflammatory.
MMP, yeah. Okay, thank you. Thank you so much.
Any other questions?
Yeah, I have one.
Yeah, please.
Thank you, Ivana. It's very nice topic, actually. I have just one question, and then probably the easy one. How long do you recommend using these T-cell inhibitors for the patients, for the dry eye patients? 2 years, 3 years? What is the cutoff level? How many years we should recommend this kind of drugs to our patients?
It's a very good question, but we are having more and more studies showing result of the long-term treatment of this medication. But my approach is to start treatment, a minimum is 3 months, because you won't see results before. Keep a patient for a while. I would say minimum would be 6 months to keep the patient on the treatment. If there is a significant improvement, you might consider stopping for 3 months, see how it goes, and then maybe bring patient back to these medications. But I think it's safe to use it for long term with some short breaks to see how patient does.
What do you mean by, we cannot do it continuously? Some patients, they are using 2 years, 3 years of this medication. Is there a problem to use for this long period of time?
I don't see any problem, but sometimes you have a problem with the compliance. You want to be sure that it's necessary to use it or not. And sometimes the patient will ask you, do I really need to continue this medication? They want to reduce the number of medications they're using. So I think in these cases, it's worth trying to remove medication and see how the patient does. But I have very good results with patients who are using, especially patients who have some additional autoimmune or systemic diseases, who are using this medication for years without any side effects.
Any other questions? Okay, thank you very much, Dr. Ivana, for this presentation. And now we can move to our second part of this meeting today. It will be a case discussions, mysterious cases, interesting cases, and we are going to have the first speakers. So I will introduce the speaker, and George, my friend, he will continue, and all of us, we are going to discuss the case. So whatever the thing you want to stop in any time, then we can ask questions, or we can see while we are moving together. So it's my pleasure to introduce my friend, Dr. Nicholas Lapuri. He is a vitreoretinal surgeon. By the way, he is one of the pioneer vitreoretinal surgeon, and he's the boss of vitreoretinal in Georgia and surrounding area. He's a founder of Da Vinci Eye Clinic. It's my pleasure to have you here, Nicholas, and waiting also to see you in person very soon. Nicholas.
Thank you so much for invitation, Dr. Mohammed. It's a little bit inconvenient to me to jump from the anterior segment directly to the retina, especially after so great presentation. Actually, after I have done my retina fellowships, I have done my refractive and cataract fellowship, and I came to know after that the tear film is as important as a retina. So here I just came with the one case, interesting case I have done recently. It's a giant tear and the large macular hole after blunt trauma. So this is a patient, 65 years old lady, had blunt trauma.
But we cannot see. Can you share the screen because we are not seeing?
Okay, so share again. Share it again. Am I audible? Can you hear me?
Yeah, we can hear you. Okay, now yes. Now we can see the video, please. Yeah.
Yes. Okay. So this is a 65 years old patient, had blunt trauma in car accident, and when patient came to me 5 days later, it was 8-ball hyphema. So the B scan was done. There was a vitreous hemorrhage, and we decided to wash out the anterior chamber and clear the vitreous hemorrhage at the same time. So here was the first mistake I have done. I have just seen the B scan on the printout.
Are you playing the video, Nicholas? Are you
No,
playing the video?
I'm not. On the printouts. And I missed a giant retinal tear, which you see here. Actually, I started recording this case after I saw the giant retinal tear. And I will stop just 1 second. I'll speak the introduction. So before I went to the vitreous, actually, I have done here the washout anterior chamber. I saw that it was a dislocated lens. I have done the cataract with the CTR implantation and an IOL. Then I went inside. I just thought it was a vitreous hemorrhage, just do a simple vitrectomy. But this is after I cleared the vitreous hemorrhage into the anterior part. I have seen that there is a giant tear. So we have the superior giant tear, and the retina is torn about 180 degrees on the superior quadrants. And then I'm reverting here the retina. I'm starting the video, and you see here is the large macular hole. So this patient is having some choroidal ruptures as well, some hemorrhages under the retina. And now our plan is to treat the giant retinal detachment along with the macular hole. So first, what I'm doing here, I'm shaving the vitreous. It's a inferior part. I'm just alternating the infusion and the chandelier, and where the infusion goes, I'm just not to use a third hand of the assistant. Where the infusion goes, I'm indenting that part and approaching from another trocar with a vitreous cutter to clear the vitreous. So it's a projection of the giant tear. I'm removing the anterior lip of the remnant of the retina. So as you see here, I cleared the inferior part. I made a shaving of the vitreous space as much as it was possible, and now I'm shaving the superior part, the vitreous, along with the anterior retina. So the next, in the meanwhile, here comes there is iris dialysis as well. It was during the trauma, and I just left it for the second procedure. So I'm removing the epithelium because it was swollen to improve the visualization, and staining the ILM here and using the PFCL to flatten the posterior pole. So this is all done with a wide angle viewing system. And now I'm cauterizing the vessels because I'm planning to trim the anterior part, the posterior part of the giant retinal tear all along the 2 quadrants. And I'm not using actually the continuous cautery in most of the cases. I use just only the major vessels I'm cauterizing. Here I'm using the RV lens, which gives me the high magnification and the high stereopsis. And you see that inside the hole there is the blood clot which just moved from the periphery of the retina. So here I usually don't use this technique in routine cases, but here I'm using the inverted ILM technique, which I perform under the PFCL. And usually I was thinking about, and later on the discussion, I want to ask you whether you would remove this clotted blood from the hole or not. But usually I left it because I was thinking that this blood will help me to close the hole as well. So you see that I'm flipping the ILM over the large hole. Now this is a 25 gauge system, and doing this pulling under the PFCL. So once the ILM inverted flap is done, then I'm back here to treat the giant retinal tear. So I add a little bit more PFCL. I will run a little bit faster. Okay, so yeah, so before the PFCL, I'm trimming the edges of the giant tear. It was a multiple holes inside. And then I will add some more PFCL up to the periphery, just to perform the laser. So I just want the most of the giant retinal tear edge to be covered with a PFCL. So after the laser, it's filling with the PFCL here. And you see, so the first line I'm using just the continuous laser, and then I will add 2 or 3 more lines. Usually I don't do 360 lasers in those cases, but in this particular case, I was planning to travel for a long time, and I have done it for 360 laser. I'm not still sure that this 360 laser is better than just doing a laser. It's a giant tear projection. So then so of course laser cannot be done up to the aura serrata until you do some fluid air exchange. Usually, of course, we have the superior giant tear or any kind of giant tear. We have a high risk of the retinal slippage. That's why I'm going to do the PFCL siliconol exchange, but everything I'm doing under the air infusion. So I do the partial fluid air exchange and I dry up the edges, and then I'm adding the laser on both sides up to the aura serrata. After that, I'm pushing the siliconol over the PFCL. The air is continuously on, so I exactly know what's the pressure inside my eye. And there is a little bit problem of visualization because under here, the silicone oil, it just has some layer of the foam shape layer, which just prevents you from the good visualization, but still you can manage it. And you can see that the air is on the top. In the middle, there is a silicone oil. Under is a PFCL, and I'm removing the PFCL completely. And then under the direct visualization, I'm accomplishing the silicone oil fill. The last bubble of the air is gone. Here you see the dialysis of the iris, which is left for the further management. And this is pretty much end of the case. Here I used the 1300 light siliconol, and this is how it looks after the surgery, 2 weeks or so. And this is OCT. This patient can see 20/400 because of its a V-type macular hole closure. And we are planning to remove the siliconol within 3 or 4 months here. So this was pretty much everything I wanted to show you. Please, now the floor is open for discussions, and maybe something would you do differently, or you have some questions about the case. It's my pleasure to answer it.
George?
Wow, it's a beautiful surgery.
Thank you.
I'm so impressed. I have some question, but I think many people have some question as well. And you did great because you have a trauma case and also with macular hole. And the only thing that might be different for me is I'd like to remove 360 the interlimitant membrane. In idiopathic macular hole, I use the flap technique for all. I don't remove 360 anymore. But in trauma case, if I'm assumed that's mainly by tractional, I would like to remove, but the result you have is perfect. It's very nice. And another thing you did that's very nice, you start with fluid exchange, and you dry very nice the edge of the retina, and then you start to go for oil, and at the end remove the perfil. I never did that. I just have to try. I don't know how difficult it's to remove the
Yeah.
perfil at the end. I use only fluid gas or oil fluid directly. You did 3 parts. It's nice, and the result's perfect. I like very much. But one thing I'd like to ask you: you remove a big part of the retina. It's because it has intraretina PVR. I mean, shortness of the retina, or just because you think it's better to remove that part?
Actually, I have removed the anterior lip of the retina, not because of the PVR. Of course, it was a fresh case, and there was a very short time for the PVR. But I did it because it was too much shrinkage, so it was multiple holes inside, so it was torn, and it was like not healthy appearance of that part of the retina which I have removed. And that's why, just to leave this retina, then I should have done a lot of laser over there, just to not to miss any small break inside there. That's why I just removed the as much as I get until the healthy tissue of the retina. So this first part. Another, in terms of the inverted flap, usually inverted flap I use mostly for the idiopathic holes. I use a conventional peeling technique, and smaller is a hole, I do smaller peeling zone, larger is a hole, larger. But when it goes over 1,000 microns, and of course I didn't have here any solution to measure it intraoperatively, but from the look, it was probably about 900 or 1,000 microns, and that's why I use the inverted flap. However, still I'm not sure whether the inverted flap in this particular case did a better job than it would have done the conventional peeling technique. As we see here on OCT, it's a V-shaped closure. Of course, we are not happy with this type of closure because we are missing most of the photoreceptors from the center. That is why the best corrected visual acuity is not that good. The other technique, which is concerning to the PFCL silicon exchange, I'm doing this under air. I'm doing this for many years now. So first I was doing the direct siliconol PFCL exchange under the BSS, and of course it has its dark sides as well. So, but mostly we don't have exactly any idea while we are injecting the siliconol inside the eye what's our intraocular pressure. And sometimes I have seen the cases in discussions, different conferences, a ruptured globe or the siliconol into the anterior chamber, many other different kind of. But the visualization, of course, there is much better to compare to under air exchange. But with the air, when you do the continuous air exchange and then under air you do the PFCL silicon removal, there is always this problem is the foam-shaped layer which appears onto the top of the silicon, which doesn't allow you to see very well the small bubbles. That's why you need to alternate different kind of visualization systems, like with a wide field lens to change with a high map lens. In case if you use every side of the biome. But usually here I use, in most of my cases, I use the contact wide field lenses, unless there is a macular peeling needed. The macular peeling, I'm doing the flat contact lens, which gives me the higher magnification and better control. These are all the tricks what I use mostly for the giant retinal tears. And there is another question I want to ask the panel. If anybody uses the scleral buckle in addition with a vitrectomy for giant retinal tears?
Nowadays, I don't use more. I go directly for vitrectomy. I trim all the retina skirt and the periphery, and go for the. If I feel good, I can leave with 3,3-FA gas, but most of the time I leave with oil for a while. For now, I don't use more the silicone band. Tatiana, go ahead.
Yeah. Thank you so much, Nicholas. Very interesting case. Hello. If you remember, I showed the same case with retinal detachment in Georgia, with retinal detachment and macular hole. I would do the same, put silicone oil in partially air-filled eye, leave the bubble of PFCL not to shift the inverted flap. But frankly speaking, I would remove the hemorrhage from the hole. I would make it clear, because I think it's an obstacle. This hemorrhage does not allow the edges to get closer. Maybe it's the reason of closed hole, but not completely. And I would not buckle, of course, because it's not retinal dialysis. The reason is traction of vitreous. We should do vitrectomy and not buckle.
Thank you. Thank you.
Very good. Anybody else?
Dr. Sibel or Dr.
Yeah,
Wild?
yeah, I can make a quick comment. First, congratulations, Nicholas. It's a very nice case and very difficult case. Probably I would have done the same thing mostly, but as Tatiana said, probably if it's not sticky, the hemorrhage inside the hole, probably I wash it away with the passive fluid aspirator, because I agree with Tatiana. Probably it prevents from reapproaching the retinal layer close to retinal layer. And the other thing, I do the same thing to probably ILM flap, because it's very large macular hole cases. And finally, it's very interesting. Thanks for sharing the triple layers, the air fluid exchange and the decalin as well. It's a very nice trick. Thank you very much.
Thank you so much. Just with regard to the hemorrhage, actually, I was thinking about it was much easy to aspirate through the PFCL, just to aspirate from the hole this very thin layer of the clotted blood. But I was thinking there's a lot of studies. It was in an old school of thought in complicated macular holes to use a blood clot to facilitate the closure. This was the reason why I left it. So.
Yeah,
but the bubble of this clot should be bigger to cover all fovea area, to make these edges closer.
Yeah, to use this fiber.
Not inside the hole. Yeah.
Actually, it was under. It was under, like it. Yeah.
Yeah. Nice case.
The hemorrhage maybe you should remove, but another thing that three things that I'm just pointing out. One is, as I said, I used to flip the flap mostly in the idiopathic macular holes, but when I have retinal detachment together with macular hole, I used to 360. Why my idea? Just because I think it's more tractional, and the retina is detached, and then we have enough tissue to approach the size. Another thing that maybe I'm gonna try with a huge hole like this in a retina detachment is just get some piece of the retina and make autologous retinal transplant, because it's too much easy. You have already the retina detached, just to take a little piece and just move to the hole, and you have the retina. But anyway, we're just discussing the possibilities, because when you are inside the eye, you always has many possibilities and try the best. And I think you did, and it was beautiful. Thanks so much. I think we should move for the next case, because macular hole can discuss 1 hour, 2 hours, and still on. And then we have another beautiful case. I think Sibel gonna be the next one, and Mohammed gonna
Dr. George, we have 2 comments, please, if you don't mind. There is a comment in the chat. One from Dr. Ihab Saad. Yeah, Dr. Ihab Saad Osman. I would like to welcome Dr. Ihab and say hello, Ihab. Nice to be with us. Dr. Ihab, a well-known also friend of us, he is specialized in everything, pediatric, retina, everything. So Ihab is a multitask guy. He is commenting, we usually do a retinectomy from mobile to mobile retina, and it sees you remove a pill sheet tissue as well. Can you comment, Nicholas, about that?
Yes, yeah. With regard of the autologous retinal transplantation, actually I have done few cases, and my impression, of course, I didn't do a lot of case to make some solid statements, but my impression is that in my hands, it's not as successful as more or less conventional techniques to address the macular holes. Because actually my impression very initially it was that this macular hole is not something which was not able to close. Actually, either with an inverted flap, or in case I have the silicone hole there, I'm going to go inside and do a silicone hole removal. In case if it is not closed, then I will do the complete peel or something else. But for the retinal transplantation, I would think as a last option, not as a first case, because I have a case I have done the retinal transplantation not with a good outcomes at all. That's why I'm a little bit skeptical with this technique. Maybe under my hands it doesn't work. That's why I have tried it enough, and I just gave up from this technique.
Nicholas, we need a very short answer also. Would you consider closure of if the best corrected visual acuity improved, referring to this case and OCT?
You mean as a
There's a
second?
comment. There is someone is asking this one. I don't know. He said, would you consider closure if the best corrected visuality improved?
Okay,
I
so
think maybe he said to
I'm
go
not
back,
getting this
to
question. Yeah, I'm not
go
getting.
back, I think, and do again a closure of the macular hole.
You know what? I don't think that if I do, okay, I have shown there the OCT, and the part I have done the peel. Actually, the neurosensory retinal thickness, as we all know, the ganglion cells, they are getting dry up, and that's why we have
A gap, like
you
a
can
gap.
call it atrophy or whatever. So the thickness is much less. And I don't think that while I'll be removing the silicone oil, I need to do the 360 lamp peel, because I will traumatize the retina more, and I don't think that it will gain me much more vision than I have now. So that's why with lamp peeling or ERM peeling techniques, we have to be a little bit careful while doing these procedures, because all days I was doing just a peeling with a high magnification indirect lenses, and when I switched to the high magnification flat contact lenses, I understood that I have been missing a lot of things. Actually, the pinching, how much you pinch, how many times you pinch, at what topography you pinch, exactly taking the lamp. So these things actually is I changed my outcomes once I switched with a high magnification and the better stereopsis, because less trauma you apply onto the eye, the better results you get. And
thank you very much,
you.
Nicholas.
Thank you.
Thank you, and thanks a lot for this very interesting discussions and great um, work and great achievement in this case. Thanks a lot. So we move to the next speaker. I would like to welcome Dr. Sibel Demirel. Sibel, she is an MD at EPO, Professor of Ophthalmology, Ankara University, Faculty of Medicine, Ankara, Turkey. Dr. Sibel, thank you for being with us for maybe the third time we are here together.
Mute.
You are mute.
Well,
you are mute. Can you? Okay.
Thank you very much again, Mohammed and Georgia. It's a great pleasure to be here with you. My topic is or mystery case is coincidental white lesions in choroid and retina. Let's see what's happening in retina and choroid. And the case is the 25-year-old male. He was referred to our hospital for further evaluation for decreased vision in his right eye for 5 years. And there is no pain, no trauma in his history, no systemic diseases, there is no medication. He's not on any kind of medication. And there is no consanguineous marriage in his family. Just one thing that his father has decreased vision problems since his childhood, but there is no diagnosis. Since he has a big family in the suburban area, we couldn't get much information from him, but this is the only thing we know from his history. His visual acuity 20/100 in his right eye, 20/20 in his left eye. Anterior segment was unremarkable. Dilated fundus examination was unremarkable. IOP was normal in his both eyes. There is no pupillary defect, abnormal neuro-ophthalmologic examination finding. There is no vitreous cells. The vitreous is clear actually, almost nothing. These are the color fundus photographs taken by Claris wide-angle system. As you see here, optic nerve and the vascular system looks pretty normal, especially in his left eye. Maybe we can see some changes in the foveal area in his right eye, but I'm not sure about, at that time, I was not sure about the diagnosis when I saw the patient's fundus, and I thought that this is normal. Let's see what's happening in OCT scans. As you see here, I was surprised when I saw these pictures. As you see here, in his cross-sectional B scan OCT, there are something hyper-reflective in the choroid area, actually, because those are the infrared images, and that's why the problem probably are inside the choroidal layer. And at first sight, I couldn't recognize what's happening in the choroid with just the infrared images. But corresponding to that, the lesions, actually, this is just one section, EDI OCT. And as you see here, there is almost nothing in the left eye in the OCT scan, but there is some angular sign in the center of the fovea, as you see here, like the angular sign of Hendla fiber layer in the center, but still I'm not sure about the diagnosis. Choroid thickness are maybe thickened choroid, let's say, but the patient is just 25 years old, as I mentioned before. Let's see what's happening corresponding to those areas. As you see here, corresponding these hyperreflective areas in infrared images, there are some hyperreflective tissue in the choroidal area. You cannot recognize the healthy choriocapillaris, saddler-hallar layers in that area. There is some mass or mass-like structure, something hyperreflective. Maybe this is just fibrosis, nodule, or something inside the choroid corresponding that area, as you see here. Those are the wide-angle infrared pictures, again, taken by Heidelberg system. Those are the shortwave blue fundus autofluorescence pictures. The left one is normal. The square hyper autofluorescent area is normal, actually. This is just an artifact because the probably technician put too much, light for taking the picture. But in the right eye, there is some hyper autofluorescence area like what we see in hereditary dystrophy. So I was very confused. There is something inside the choroid, and also there is something in the retina characterized, which is very characteristics for hereditary dystrophy. So those are the indocyanine green angiography pictures, because I saw something in the choroid, and that's why I want to be sure about the diagnosis. Not missing the...
Can we stop here for a while if you don't mind?
Okay,
just we want to take opinion before we go further.
Okay.
I need Weil. Now this hour, the most pioneer comment. I want Weil if he can comment and tell us what he is thinking.
Okay, let's have some ideas from the panelists. Okay.
Sibel,
yeah,
what a case you brought to us. It's amazing. It's difficult, it's beautiful, and it intrigues me. I think Vahel is shaking because he loves kind of challenging things like this. And I just briefly say that it's something deep that you can see by infrared. Let's go for deep. It's in choroidal and looks like some choroidal infarcts. That's in the chorocapillary. But I'd like to listen first after finish my discussion, Vahel, because he's expert here in difficult case. Vahel, you're here?
Hi.
Why?
Yes,
Why?
I'm following. Yes. Uh, Actually, I'd be interested to go back to the B scans and for yes. So anatomically, you have infiltration or whatever hyperreflective lesions in the choroid primarily, and you have some hyperreflective lesions in scattered in the left eye and all the layers of the retina. Taking into consideration the age of the patient, which is 25 years, I and the bilaterality of the disease, I would think first of systemic diseases with which can infiltrate the choroid, if you would agree with me, Dr. Sibel.
Yeah, agree.
So I don't know what's the incidence or the prevalence of of TB in Turkey, but I would go with the inflammatory differential like TB sarcoid. And for this, if you did hematological testing, and if it's it's no hematological disorders like lymphomas or whatever, then it needs a systemic workup.
Yeah.
I mean, you pick up the signs, then you follow it, and you need a systemic workup. So what did it turn to be?
Yeah,
Any
agree.
other comments from any other, Dr. Nicholas
Yeah,
or Tatiana?
well, I agree with you. We can think in TB that we can has tuberculosis in the choroid, also sarcoidosis. That's you can have another thing, but the patient is too young. We can have multiple metastases, but used to be more old people and used to be for lung or from breast cancer, and then we can see
He's a
any
male.
cell.
He's a
We can
male, not a female.
Male.
male,
Male.
but
Yes,
we can have lung and also men can has breast cancer. It's very quite might rare, but I had one patient with breast cancer, male. And another thing, you can't see any cells in the vitreous, inflammatory cells. I'm trying to see here, but
No,
in
there is
my
no.
side here, no cells. Because of no cells, I'm just thinking about some kind of focal choroidal infarcts. Because if you go for focal choroidal infarcts, we can have any inflammation, but the case doesn't have any inflammation. It's just in the vascular area, we have this hyperreflexure in the choroid that's pretty much sick choroid for even a young guy. But if you look, it's huge choroidal mass. And then maybe this patient has like thrombus in choroid, can be. And if I go out from inflammatory disease, just because I can't see any cells, this is my point of view. But as I said, Sibel brought us something very challenging. We need to think a lot.
Nicholas,
You know, definitely.
you have anything different?
It's a no, nothing different. Actually, I was thinking about the PIC before I saw the autofluorescence, but now, of course, so definitely something is happening on the choroid, but not in the neurosensory retinal ZRP. And it's very interesting to see the ICG and FA. You know, the maybe it will give us more.
Tatiana, you have something to add?
No ideas. I just
Okay, I
want to
will
hear.
add something, not mine. I think Ihab, he is running very fast before us. Ihab, he suggests a regressed granulomatous lesion, or very rare to have regressed leukemia or lymphoma infiltrate. So
Very
this
good
is
idea.
another.
Leukemia, lymphoma. It's good, Ihab. Thank you.
Yeah. And also, what is his immune status? Is his immunocompromised or not? So let us now see what Dr. Wael asked for, because I think this all Dr. Wael suggests, and we are waiting for Sibel to inform us, please.
Just regarding the metastasis, it's very unusual for the age. And I have seen many cases of metastasis. They are all usually accompanied by high exudative retinal detachment. And it's not those many spots. You usually get one or two lesions. They are creamy. You can see them clinically. But I didn't see metastasis like this.
We
Yeah,
can
did
wait
not.
and see.
very young person, and they very small. I just put in the differential
Lim-
diagnosis just because we have metastasis in the choroid. But you agree with you,
Yes.
the age is out, and we have
Oh,
very
exudative
clinical
detachment.
characteristics. I agree.
Sibel? No.
Okay. Shall I go with the presentation?
For
Yes,
sure.
that's why we are
Everybody
waiting
is
for you.
curious.
Please,
How the audience is
please,
curious.
One by
please.
one. So let's say that he's healthy. He has no malignancy. He is not on any kind of medication. There is no cell. And this FA. So what do you think about those pictures? Right side, left side, an early phase of fluorescein angiography and early phase of indocyanine green angiography. As you suggest, there are something in the choroidal layers because we see hypofluorescent lesion in the early phase of indocyanine green angiography, which means either there is choriocapillaritis or something, some mass, granulomatosis or malignancy, whatever, in the choroid, and they blockage the dye coming from the choriocapillaris. We'll see. And as you see here, on the FA, there are some window defects on the temporal side, which is very well localized, aligned with the hyperautofluorescent area in fundus autofluorescence picture. Shall I continue? Any
Please,
ideas?
yes.
One second,
Yes,
just
please.
to add more spicy in the discussion. This lesion here in the autofluorescence, we can remind me peak. We have some small area of choroidal ischemia that is because of the inflammation.
Okay.
And it's most in myope woman that's young, but
He's not
Dr.
myope.
George, you mean the PIC, the inner choroiditis?
But George,
But we have nothing on the autofluorescence.
peak, there is no peak lesion here.
Yes,
Totally
exactly.
healthy RPE.
Yeah.
Yeah, that's true. But
This
I'm
RPE
just looking for the
Indocyanine green angiography.
indocyanine green, this area of ischemia,
Yeah.
hypo. That's looks like the peak lesions in the
Yeah.
in green. That
Yeah.
is, this area is hypoflux. That
Yeah.
means we have some infarcts in the suprachoroidal area.
Yeah.
Chorocapillaris. I mean,
Yeah, chorocapillaris. Yeah, PIC is a kind of white dot disease, is a kind of white dot diseases, but if it is PIC, we should see some kind of RP changes, very sharp atrophy in the optical coherence tomography, optical coherence tomography.
Yeah, the PIC, you have the choroidal capillary ischemia, and you have RP disturbance.
Yeah.
Together, because all the diseases is autoimmune in the area RP choroidus. That's it's complex. That's
but RP is healthy here. Let's go. They totally disappeared here. What we saw in the early phase of indocyanine green angiography, which is hypofluorescent lesion, patchy lesion, totally disappeared in the late phase of indocyanine green angiography, which means that it is not there is no total blockage, full thickness choroidal mass there in the choroid. And also, this is not choriocapillaritis, because as we all know that serpiginous, amphiginous, peaks, whatever, they continue to be black in the late phase of indocyanine green angiography. And I thought that these are the not full thickness choroidal mass or nodule or something in the choroid. This is what I learned from these images of course, we need to go further with the all the tests. I will show you in the later. Shall I go continue?
Yes,
Or-
please go ahead.
Okay.
Something?
And again, the patchy
Nicolas
hypo.
want to say something before? Okay,
Actually,
Nicolas.
Actually, is on the right eye, especially on autofluorescence and the fluorescent angiography, say arcuate lesions, say arc-like lesions, actually doesn't, it resembles clinically. I wouldn't exclude the syphilisis as well. I would have done some syphilis test as well for this patient.
Yeah.
Just to exclude.
Yeah. Okay. We did.
Yeah, I'm sure that you.
Yeah, we did. Diagnosis. The first, the infections, inflammatory choroiditis, choriocapillaritis, like you said, syphilis, TB, sarcoidosis, whatever, all those kind of things. And the second thing is that there is for sure retinal dystrophy especially in the right eye, more prominent in the right eye. So what's happening in the retina? Are those coincidental, or is there any relation between the diseases? We'll see. So we order blood test and the genetic test. This is the result of genetic test. Decrease in rod response in both eyes, more prominent in the right. Decreased cone cell response in the right eye. Cone cell response in the left eye is normal, looks normal. So a kind of rod cone dystrophy in both eyes, but it's more prominent in the right eye. Blood test results are negative regarding ACE, lysozyme, syphilis, quantiferon TB gold test is negative for the cases. Are you ready for the results? Shall I continue?
For sure.
Yeah, we need a surprise.
Yes.
Okay. Let's see what's happening. Those are the results for genetic test. The patient is positive ABCA4 gene mutation, which is part 1. The other one is the patient has neurofibromatosis 1. And the patient has cafeola spots all over the body. And the patient's brother was operated for the optic nerve glioma, which I didn't mention you at all at the beginning. So we'll see what we have in ABCA4 mutation. Easily, we can say that usually we see the Stargardt disease, but as we all know that we have different phenotypic types when we have ABCA4 mutation. The patient can be totally normal or have a Stargardt disease, cone rod disease, and retinitis pigmentosa. So the patient has kind of a rod cone dystrophy. This is the first part. And the most interesting part, at least for me, because I never see this kind of patient before, according to the recent literatures, choroidal abnormalities detected by near-infrared images, like these choroidal nodules. This is new diagnostic criteria for neurofibromatosis 1. And even it's more valuable than leash nodule in the iris tissue. So as you see here, those are the nodules. You cannot recognize anything in the fundus autofluorescence picture and the fundus autofluorescence pictures. However, they are pretty obvious in near-infrared pictures. And according to the literature, this is the final slide. These lesion occurs at the level of the choroids. Those are hamartomatous nodules, and those are called as Yasura nodules. And they were attributed to hamartomose lesions similar to leash nodules we see in the iris tissue, and presence of at least 2 choroidal abnormalities. If you see 2 choroidal nodules in the near-infrared tissue, it can be assumed that the diagnostic criteria for neurofibromatosis type 1. Thank you very much.
Thank you.
Wow.
Thank you. Thank you very much.
The Retina Society, no? So good. Congratulations.
I think George, she fake us from the start. She didn't tell us the story. I mean, there is a skin problem. It was there.
Yeah, optic nerve glioma in the brother. Yeah.
Okay.
Yeah,
So
that was nice to stimulation our imagination,
imagination and thinking.
And
Okay,
thank-
so it
Amazing.
was very nice. Thank you very much,
Fantastic.
Sibyl. As usual, very interesting case and very right and good way, presentation and attractions. So I think we can go forward. I have only few comments. Maybe I will see what he mentions. Yeah. What?
Yeah,
Okay.
just
No,
yeah, it's a
nothing.
nice case, and it's a nice case, Sibel, and it's very rare. Actually, on the clinical practice, we stop with at the step where we exclude treatable diseases. But you courageously continued with the genetic testing, and for us, it's always, hampered by the expenses and the abilities to get the genetic testing. So you are it's a very nice case. Very nice case. Thank you very much.
Thank you. My pleasure. Thank you.
Okay, so we can move to the next, George.
Yeah, the next case, if I'm not wrong,
Tatiana.
right now it's gonna be Tatiana.
Yeah.
Tatiana,
So
a very good
Tatiana.
friend from Russia, and also
Yeah.
has a wonderful case, surgical case. She's a fine surgeon.
Thank you so much for your kind
Welcome, Tatiana.
invitation. Yeah, thank you so much. Can you hear me?
Yeah, we can
Yes.
see and we can hear.
Thank you. Amazing case, Sibel. My case is typically a surgical case. It's not so complicated, but I hope you enjoy it. So, the patient, male, 76-year-old male, he came to us with cataract and vitreomacular traction of both eyes. I decided to start with worse eyes, right, and then continue with left eye. Or no, first was the left one, the left one. So everything goes as usual. After phaco, I started vitrectomy, and co-vitrectomy was performed. After that, I stained a little bit by triamcinolone to make visible the skirt above the macula, made a circle, cut it in a circle, and started induced PVD. Can you see the folders in the macula? It appeared, and there was in other folders, and some promination from the choroid and retina. Also, some small breaks appeared during PVD induction, and the promination was gradually increased. So any ideas what to do with this promination of choroid and these folds?
In the middle of the surgery, start to have the choroidal detachment and these folds.
Yeah. Even in macula.
Yeah, you increase the intraocular pressure and ask the anesthesiologist to see if they have the blood pressure is normal.
Everything was normal, and there was no any hypotony inside.
May I ask you, Tatiana? May I ask? So the question is whether you have been operating this patient under general anesthesia or local anesthesia.
Yeah, I showed you occasionally the next slide. Yeah, it was both. It was intravenous sedation and
The patient was awake.
to the vein. Yeah, and it was peribulbar local anesthesia.
Yeah, sometimes this happens helps. So it happens. It happened with me a couple of times. especially high myopes. But this patient obviously is not high myope. But sometimes, usually, what we do when we do this, a 25 gauge system, probably is a constellation. What's your preset of the infusion pressure?
20.
20. So it's a
No, 20, 23, 23,
yeah,
22.
23. Usually when we do the corvitrectomy with a full pay, so usually in the eye, it goes down. Actually, whatever we have on the machine, usually when we do the corvitrectomy is 25 gauge or whatever gauge with the constellation. In most of the cases, the IP is not activated, and we are getting much lower pressure in the eye. So why I'm asking whether patient was awake or not, because sometimes it helps us, because if there is the choroidal detachment and there is accumulation, there are two kind of fast fluid accumulations. Either there is a hemorrhage, suprachoroidal hemorrhage, and in those cases, usually it's associated with a pain, and patient is telling you that I have a pain in the eye.
Yeah.
So it starts suddenly, and usually you can't explain why the patient is getting pain. It is one of the diagnostic signs that there is a hemorrhagic choroidal detachment. However, it may happen that it's very interesting to me how it happens. Sometimes we have the accumulation of the transudate under the choroid, and sometimes I had the cases when I was trying to drain right away, and some yellow color fluid was coming out instead of the hemorrhage, and this is which helps us to differentiate whether it's a hemorrhagic choroidal detachment, suprachoroidal hemorrhage, or it's a detachment due to the fast transudation of the fluid under the choroid.
Thank you. There was no any pain. Nothing. Everything was nice for patient, for anesthesiologist. Everything was as usual.
Tatiana, is it
Only
progressive
this.
or is it progressive?
Yes, I showed you it. There was nothing from the very beginning, and it was gradually increased, but it stopped
Tatiana,
like it was in this picture, like you can see in this picture.
Tatiana, two things that I'm just thinking now. One is if the infusion got lost the position and start to infuse suprachoroidal. Another thing that's happened to me in the patients a long time ago, I had, after start the surgery for a while, start a retrobulbar hemorrhage. That's during the surgery start to be bigger and bigger and start to compress the wall of the eye, and looks like choroidal detachment. And these things is terrible because may interrupt your surgery, because sometimes it's so swelling that can open the leads.
Frontotomy.
Yeah, and then go ahead. Let's see what's happened in your patients that caused that.
Let's see. But what I continue with macular area, made sure that there was no any traction, and this is the final moment inside the eye. But I saw something from the transparent part of the diaper, and I decided not to do anything, because after the surgery, I asked patient to move his eye. I saw as you said, the hematoma, and there was nothing from the very beginning. And this picture in 2 hours after the surgery, you can see the big eyelid, and there is a hematoma that happened from the very beginning, but was increased.
Yes, nowadays people use very strong anticoagulation drugs that sometimes just start to bleeding without no cause, because we start this doing everything normal, and it's not usual at the middle of the surgery start to bleeding for retrobulbar space.
Yeah, really. These pictures illustrate the 3 months follow-up period. I operated his other eye. Visual acuity was much more better than in his left eye due to atrophy of RP. And my take-home message is, remember about subtenual anesthesia. At the same time, we have fresh publications with almost the same results of the absence of pain and the same, almost the same complications between both type of anesthesia.
Yeah.
Thank you for your attention.
Nice
Very
case.
good case. Congratulations.
Thank you very much, Tatiana, for this
Thank
very
you.
nice and interesting case.
Happy end. Yeah.
You remind me, because I had something like this a long time ago. It was because the patients used some kind of new anticoagulation drugs, and start everything nice, but after a while start to swelling, and was a retrobulbar hemorrhage.
Actually, I'm a big fan of retrobulbar anesthesia. All of my cases almost I'm doing with a retrobulbar and the sedation. But actually, if it happens, if the hemorrhage happens, retrobulbar hemorrhage, there are two kinds of, it's a venous hemorrhage or the arterial hemorrhage. If the arterial, it goes very fast. And in those cases, we need to do the lateral cantotomy. It's very, very, very rare. It never happened to me. But I have seen a couple of venous hemorrhages. Usually, before you start the case, usually you can notice it because it swells and then the color changes under the skin. So it never happened to me during the case, unless when you block, you start very fast. I don't know. It never happened during the case, retrobulbar hemorrhage, but it happened before I started the case. So most of the cases you notice this.
Any other comments before we move to the last but not the least? George,
Let's go.
you have any? Okay.
Yeah. Now we have
So
a very
we
good
have
friend.
now the most prominent guest for us today, also well-known figures in our area and Egypt, Dr. Wael Osman El-Haj, and he is a professor of ophthalmology at Zagazig University, Egypt. Dr. Wael, we are very happy to be with us and waiting to listen to you. Dr. Wael?
Yes, I'm sharing.
Okay.
So, first of all, it gives me great pleasure to participate in this esteemed webinar. And I would like to thank the organizers, Dr. Mohammed Al-Amri and Dr. Jorge Rocha, for their kind invitation. Two very active and well-organized figures, recognized figures in the field of ophthalmology. The case or two which I'll be presenting are not difficult or tricky, just simple cases of type 3 macular neovascularization, and I will tell you why I chose them. Age macular degeneration is the third most common retinal disease encountered in ophthalmology clinics in Egypt, after diabetic retinopathy and retinal vascular occlusion. It accounts for 8.7% of all subtypes of blindness worldwide. The earlier the precise diagnosis is better treatment response and outcomes. In the US, wet AMD is the most common disease in retina practices. Severe vision loss in AMD is the result of macular neovascularization in 85% of cases, whereas geographic atrophy is responsible for 15%. And it's worth noticing that the development of one or both complications characterizes the late form of AMD. Any ophthalmologist to be involved in the management of AMD will be bombarded with those terminologies, which are proof of the heterogeneity of the disease. So it was necessary and mandatory to finally get a new consensus nomenclature for AMD. And CNV was replaced by MNV because of this type of 3 macular neovascularization. And here we can see that type 3 macular neovascularization is the least common, according to the RAP study report number 7 released this year. And the reported numbers mirror the rate in my clinical practice, which I find it in less than 10% of the cases. So the question, is it important to classify neovascular lesions? And the answer is definitely yes, because the natural history and the treatment strategies and outcomes differ according to the MNV subtype. Type 3 MNV is special in its diagnosis and management, and though it is sensitive to anti-VEGF therapy, yet the development of macular atrophy before, during, and after treatment is a major concern. And we may all agree that the practice of medicine is shifting toward tailored treatment and patient safety focused on the reduction of both diagnostic and procedural errors. So I'm sharing the clinical characteristic of this very patient, where this is a typical case of type 3 macular neovascularization, where we can see the subtle pseudodrusen in its very common location in the upper temporal area of the macula. And here we can see the very characteristic flecks of retinal hemorrhage. On fluorescein angiography, it shows focal area of hyperfluorescence that becomes more pronounced in the late phase, what we call a hotspot. But when we look at the magnified image, it shows the abrupt curving and the turning of the feeding arteriole in the retinal tissue toward the angiogenic network. So it's most probably it's a multifocal or bifocal case of type 3 macular neovascularization. When we dig in the OCT, the most important sign here in the ACT or in the OCT is to find an intraretinal hyperreflective lesion at the junction between the inner nuclear and the outer plexiform layer, because it's related to the deep plexus of the retina. We see intraretinal fluid, and the third is the hyperreflective foci. We see the reticular pseudodrusen appearing as projections from the retinal pigment epithelium, and we see the down deflection of the outer plexiform layer. And here's the right eye, where we can see the hyperchoroidal transmission showing a geographic atrophy. When we look at the OCT, we see pathological flow on the outer retina or the choriocapillaris. So by seeing this, we are excluding type 2 MNVs. And by the last report just released this month, we found intraretinal fluid, hyperreflective foci, and retinal thickening, which are considered isolated risk factors and biomarkers for MNV stage 3. Regarding the staging of this case, it is considered stage 1, stage 2, which is, yes, the earlier we start treatment, the better. But what happens here that this patient, I injected her with three times with Eylea, and it shows very well that the CME almost disappeared, and there is consolidations of the hyperreflective material here. But this is the situation which is always not good. When we look at the case before and after injection, we can see that there is enlargement of the geographic atrophy, of the macular atrophy, and that was very fast during 5 months. And this is the main problem with treating type 3 MNVs. And of course, the reason you cannot point out to a certain reason, but there are many reasons, and it can be one, it can be a lot of them. And that's always my policy with treating MNVs type 3 is to look at it's the only situation where you look at the retinal thickness in managing age-related macular degeneration is to check for the thinning of the retina to dose your treatment. And regarding the second case, it was nice. I would pick it, and we cannot miss this disciform scar in type 3 macular neovascularization. We can see this scar, and the scar is whitish with a base full of hemorrhage, and the patient is 160. It was an end stage after many trials of injections. So when we dig into the details, we can see the RAP lesion here, and the slow filling of and staining of the fibrotic scar, and not to be missed with PED because it would be hyperfluorescent. So it was slow staining of this scar tissue. Also in the details, we can see the arteriovenular shunt composed of two feeding branch arterioles. Here are they, coming from the macular arteriole, and a corkscrew venule coming out of it. This, I was lucky to get such a nice picture of OCT angio, and we can see the macular vessels dipping inside the retina to reach the choroid or the choriocapillaris to create the retinochoroidal anastomosis, which is really hard to see. Looking on the B-scan overlay, we can see here the flow inside the scar tissue and reaching to the choroid, which is very interesting. And thanks to the Retinal Congress series, I was able to access the RAP study report 8, which confirmed my observation that the presence of fibrotic tissue appears to be essential for the downgrowth of retinal neovascularization and the formation of retinal choroidal anastomosis. So it's a late event that we should not wait for. Thank you very much for your attention.
Thank you very much, Dr. Wael, for reviewing this and presenting these two cases. Interesting. Any question or comment about that?
Vahel, excellent talk. I learned a lot. Type 3 neovascularization intrigues me in many ways. I have two questions. Maybe you can answer, maybe not. Usually, when you have type 2 neovascularization, have old patients with pseudodrusen or DDS, drusenoid subretinal deposit, and the choroid is thin, very thin. And the neovascularization comes in the middle of the retina. And somehow we have ischemic area in the middle of the retina that stimulates of this neovascularization. What's your idea about physiopathology and how this retina is so ischemic? Is just because the choroid, or you think the intermedial plexus is ischemic too?
Actually, there is no consensus about the etiology, but it's, I guess, the most prevailing theory now is it's the choroidal hypoperfusion. But you never know. You never know. I mean, the RAP8. I mean, they studied the heat flow and stuff like this, and they stressed the role of the choroid. But you never know on the pathophysiology. But it was very interesting and confirmatory that to wait for retinochoroidal anastomosis, it will be a late case. You have to pick it up early. Stage 2, stage 1, start treatment and be very careful starting with the patient with the thickness, because once the patient is with thin retina, then you start injecting in type 3 lesions, you get more thinning, and the patient the MNV goes away, but you are enhancing the development of macular atrophy. So it's a vicious circle that really depresses the doctor and the patient, and some patients stop, even don't like to continue treatment. That's the bad part of the type 3 lesions.
And the last question is, what's your the main image modality you think is good for cut in the phase 2, phase 1, phase 2? You think the angio-CT or fluorescein, or what's the best image modality to catch this early phase of the type 3 neovascularization?
OCT angio will exclude the other two types. So we always go with multimodal imaging, but OCTA will exclude type 2. But the best situation is you get fluorescein angiography and high quality OCT B scans, because with the B scans you can locate this hyperreflective lesion, this locus at this anatomic location, which is usually temporal to the fovea and out of the axis, related to the deep capillary plexus of the retina. So you have to have a high level of suspicion to catch up these patients and to start treatment, and to be very careful with the dosing and stopping the RP atrophy, or trying to avoid RP atrophy to gain some vision with those patients.
Any other comments?
Thank you.
Yes, Nicholas.
I have a question. Thank you so much, Dr. Weil, to give us this presentation. Actually, I'm very lucky because yesterday I had the case, a lady patient from UK, an RAB lesion. I have done all the modalities except OCT angio, because we don't have OCT angio yet. But on ICG and SD-OCT, it was very typical. But the question is, and it's a treatment that was not treated before, so just a few weeks ago started the symptoms. I was thinking, actually, I advise this patient Eylea, but we have brolucizumab as well as Vabysmo. Usually, what kind of treatment do you give? And actually, I was thinking about that offering the patient Eylea, 3 loading doses, 3 injections, and then extend to as it was shown in the trials, and extend to bi-monthly. What would you suggest? What shall I do? And then on opposite of this, we have Vabysmo to do the 4 loading doses, and then extend to every 2 months or every 3 months. In some studies, they have shown every 3 months, even not that effective as every 2 months. However, although the Vabysmo has the triple dose to compare to the Eylea 2 milligrams. So what shall I do with this patient? So how shall I start? At what drug and what regimen?
First of all, you have to
I'm sorry. It's a RAB lesion, and there is edema. It's a stage 1 mostly in this case. Stage 1. It's a very, very initial stage.
Putting in fact that type 3 MNVs are very responsive to anti-VEGF, I usually start with Eylea. And as I shown in this very case, the first one, we start with 3 loading dose. But after the 3 loading dose, you start to go with PRN, because I don't extend. I do the extend perfectly, and like the book in type 2 and type 1 lesions. But with type 3 lesions, I would be very cautious because of the high risk of developing macular atrophy. And there is high association between the presence of reticular pseudodrusen and the development of macular atrophy. And the drug itself, and it's the natural history itself. So it's multifactorial, and you cannot judge it itself. So what's the rush? You inject the patient, you load the patient, then you follow him with the OCT, and OCT is enough for the follow-up. And then you go as needed with injections, and putting in mind also his visual acuity, how it's moving with you. Because if he's not improving with vision, and you have a dry consolidated scar, and you can follow up, you can extend. So we go one by one in type 3 MN.
And how frequently, after 3 injections, how frequently do you monitor the patient? Every month or every
Yes.
7? Every month?
No. Every month. Yes, every month he comes.
And to observe the thinning of the macular atrophy, you use mostly autofluorescence, or which modality for that?
Yeah, autofluorescence. Autofluorescence would give you the general idea about like this case, it was expanding. As you can see, the geographic atrophy was expanding, and also the OCT, it shows the atrophy. It's very well, it can delineate it, but it depends that you need a high definition lines that can detect these things, and the heavy ones, it's like tight lines to detect the change. And you ask always the technician that he has to repeat the same scanning protocols, so it would allow you for the comparison. So it's not once he makes radial, the next visit he makes raster and whatever, then you have to give him instructions what to do with the follow-up of these patients.
Okay, thank you. Thank you so much. It was very helpful. Thank you.
Any other comments or questions?
One last thing, Vahel said that about the geographic atrophy is not easy to treat this patient type 3 because if you treat too much, we're gonna have control the neovascularization, but almost all cases go for geographic atrophy. And then this is really tough because sometimes you treat too much, and I don't know. I'm not sure that the anti-VEGF gonna get any worse the geographic atrophy, or geographic atrophy comes just because ischemic area. You have too much ischemia from the choroids. The neovascularization is a healing process. If you think that is there just to go for oxygen that we don't have from the choroids, and because you have controlled the vascularization, the geographic atrophy is coming, and then it's very tough disease. It's a challenge, and even with the best doctor, sometimes the visual result not so good because sometimes the geographic atrophy grows so fast that start to low the vision. But congratulations.
Thank you. And regarding vision, as I showed in one of the slides, they did a meta-analysis of like 200 eyes, and it ended up that the patients gain like one line on the Bailey-Lowy screen, 1.3 logmar values. So that's what I noticed, and that's what puts us in a challenge with the patients, to push them and to motivate them to continue treatment, or at least to continue follow-up for a PRN protocols for treatment.
Thank you very much, Dr. Wael, for this nice presentation and good discussions. Today we learned a lot. We are moving from posterior, from vitreosurgical to medical, anterior segment to posterior segment. It's a great meeting. Thank you for all. I would like to thank Dr. Nicholas, my dear friends, Dr. Sibel, nice to see you again. Tatiana, waiting to see you. So, Ivana, also thank you very much. Dr. Wael, thanks a lot. My dearest friend, George, thank you for being together today. And before we close this meeting, I would like just to announce for all my dearest friends that our meeting, MIOM conference, 6 MIOM, it will be in Dubai this year from 3rd to 5th of October, 2024. Waiting to see you all there, inshallah. And also we are going to select from this meeting and the last meeting 10 and 10 attendees who they attend for the in both of them with free registration for the conference. Before we can close, if there's anyone to say something, then we have to conclude. Yes, George.
Oh, wow. Mion and Retina Hub did a great section. I learned a lot from all of you, from macular holes to subretinal, retinobulbar hemorrhage, to Sibel with a great case, mystery case that we learned that infrared is the best way to neurofibromatosis, and Vahel with the type 3 neovascularization. That's a challenge for anyone in any place in the world. And I think the MIOM that's gonna happen in next October, we're gonna have so many good people, so many good science, but on the top of that, the hospitality of the Dubai and Muhammad and all the team of Mion. I hope everybody gonna enjoy a lot there. And I don't know if it's possible, but I was in love with the last video of the Mion from the artificial intelligence. It's possible to finish the session with that video. I don't know if you have easy in your computer to share.
Yeah, well, I think Mahmoud, can you share our video, last video, please, if it is with you?
I don't know if everybody has a chance to watch
To
this
see it?
video. Really nice.
Mahmoud?
Yeah, it was nice. I saw it. Yeah, it's with the
Yeah, I'm
it's
I'm
like
getting
the
it, Doctor.
RTL
Okay.
in the skies
Okay.
of Dubai. Yeah, seen it.
Okay, let us see Mahmoud what he will show.
Okay, 1 second.
Thank you so much for this nice evening, dear friends.
Thank
It was
you,
really amazing
Diana.
Thank you.
cases.
Thank you
Great
all.
pleasure to
Thank you
see
very
you.
much. It was nice seeing you all. So
Very
cool
happy to
meeting.
see you
Thank
all.
you very
Thank you very
much.
much.
Yeah.
Thanks a lot.
Anna,
Thanks.
your background is gorgeous.
So it's
Thank you.
winter on your side, Jorge, right?
Yeah.
It's winter. Yeah.
In Brazil, it's winter. In my city, it's not
Yeah.
too cold. It's around 20 because it's up close to the equator area. But in the south of Brazil, you can have around 0.
Ah,
It's-
in
Yeah,
which
that's
city do you live, George? Which
I'm
city are you?
living in Salvador. Salvador is state of Bahia. It's very, very north.
Very no,
It's
okay.
Yes.
it's not Amazon area, but it's hot here. In the winter time, it's 20, 22. It's pretty nice. In the summertime, it's around 35, 40.
Ah,
It's not like Dubai that 50,
50.
that's okay.
Dr. Muhammad, I'm about to share.
Yeah, please, we are waiting for you.
All the audience is waiting for you to live here. Look,
With sound, please. Mahmoud, can we have the sound with it? Okay, maybe you can hear it in your I sent to everyone. Maybe everyone is have it. I will share it in the group. So if not,
Thank you.
if
share
you
the
didn't
group.
receive it, yeah. Thank you very much for all. It was great meeting you and seeing you all after this long period of time. Waiting to see you, inshallah,
you.
for our next meeting. It will be on 16th of August. It will be a great also meeting, inshallah, another webinar. Thank you very much and good
Bye-bye.
night. See you all.
You
Bye
too.
bye.
Bye-bye.
Thank you
Thank you
so
very much.
much.
Good night.
Thank you so
Bye-bye.
much.
Good night.
Night.
Bye-bye.
Bye-bye.
Thank you.
Bye, Nicholas. See you. My regard to your family.
See you. See you. Thank you.
Bye bye. Tatiana, bye.